How do you rehabilitate a penis? Sort of, I took a picture. I had a great slide of a weightlifter with a barbell here. Just look at the back, and the barbell is being held up in his hands like this. I should have put that in, but I had to describe it to you. Okay. Maybe I just still in there. I don't know. Okay, I'm just going to grab a little bit of water. So penile rehabilitation after radical prostatectomy is really, I'm going to give you some cutting edge material here, a study that's just been released that addresses this. So people who have had a radical prostatectomy, which in many people's view is still a gold standard, at least for clinically localized prostate cancer in men with a life expectancy greater than 10 years, and I agree with that. With the proviso that, of course, active surveillance for those with very low risk disease. We know that there are varying degrees of erectile dysfunction and urinary incontinence in men following bilateral nerve-sparing radical prostatectomy, and that maximum recovery of erectile function may take up to 4 years after bilateral nerve-sparing radical prostatectomy. So just a little bit of explanation here for those of you who may not understand the anatomy. There's the urinary bladder. The prostate sits under the bladder. These are lymph nodes along the pelvic wall, and this yellow line is basically representing the nerve bundle, which is really a bundle of nerves and blood vessels that runs from behind the bladder alongside the prostate and down into the penis. And I emphasize that it's also blood vessels because it's not just about nerves losing your erections after surgery, it's also about blood vessels. So when we take out here's the normal bladder, prostate, urethra, we take the prostate out, spare the nerves, and then reattach the bladder to the urethra. So that's what we call a nerve-sparing radical prostatectomy. The original description of this bundle of nerves and blood vessels, or the neurovascular bundle, was by Dr. Walsh and Dr. Donker, who found this in dissecting fetuses, and then later on Herb Lepore, who found it in adult cadaver dissection. And that really revolutionized how we did radical prostatectomies, because we recognized that if we could get in, here's the prostate, and the nerve bundles run down here. If we could separate the prostate from the nerves, you could literally lift the prostate out from between the nerves. As long as the cancer isn't growing into the nerves, you can do nerve sparing. Now, if the cancer is right there at the nerve, say you do a biopsy and you know that the tumor is at the base or at the apex, very close to where the nerves are, then you don't want to do a nerve sparing. You're going to do a neurovascular bundle resection and take the nerve with the cancer. Because first and foremost, we're there to remove the cancer. So we're not going to leave cancer behind in order to spare a nerve. You can spare one nerve and still get a reasonable response. So after surgery, the mechanisms for losing erections basically are nerves, arteries, veins, and psychologic. So you can traumatize the nerve. A neuropraxia is basically a bruised nerve, and those nerves can regenerate. They can recover. There's anatomic integrity of the nerves. I can look at, when I'm finished taking out the prostate, say, yep, the nerves are there, I can see them going down to the penis. It doesn't necessarily mean that they're going to function properly. Okay, because you can get, and also by damaging the nerves, you get the secondary problems in the penis itself. If you lose your nerve to an arm, the arm basically, you lose the muscles atrophy. I mean, how many of you have seen someone who's had a stroke, for example, or nerve damage, cut the ulnar nerve or something in their hand, basically becomes very feeble, the muscles have atrophied? Well, that's called denervation apoptosis. Right? The nerves are important for the health of the tissue. So if you remove the nerves that are going down to the penile tissues, the penis will atrophy. The penis will get smaller, it'll get fibrotic, it may curve, we get Peyronie's disease after surgeries. It's all because of the neural trauma. But the arteries are also very important. You can have they can have the best nerves in the world, but if there's no blood flow going down to the penis, you're not going to get an erection. And if your veins aren't working, if you have a venous leak, if the veins don't close down normally, a normal erection involves the nerve sending signals, the arteries opening up, pouring blood into the penis, and the veins shutting down. So the blood stays in the penis until you're finished, and then the reverse happens. The arterial blood slows down, the veins open up, and the penis becomes flaccid again. If the veins aren't working, then there's very much evidence that you get fibrosis or scarring of the penis. And then, of course, the psychological issues, and I'll come back to those at the end of the talk. Impact of cancer diagnosis on erectile function, anxiety centered on reinitiation of intimacy, partner issues, and so on and so forth. There's a strong psychological overlay. The sexual dysfunctions I've alluded to are listed there. You can lose the erections, you lose the ability to ejaculate, you may lose the ability to orgasm, you may have pain with orgasm, you may get leak of urine when you orgasm. Climacturia is the technical term for that. The penis will shorten and the penis can curve. So these are all sexual dysfunctions that can occur afterwards, and they occur with time. So we like to encourage people, and this is where penile rehabilitation will now come in, and so that sets the background for what I'm going to talk about for the rest of the talk. So most patients will wait about 6 weeks after surgery to try to resume some form of sexual activity, usually because it takes 6 weeks to get pretty continent. It may not be totally dry, you may still have some stress incontinence, but enough that when you're lying down, you can still have some sexual activity. And that sexual activity may be masturbation with a soft penis, and a lot of men can't orgasm with that. Very often, men will complain of a pain, either deep in the pelvis or in the penis, when they resume activity after surgery. And as I said, many men can't achieve an orgasm, even without an erection, but they clearly can't have intercourse. What is the real incidence? We just don't know. And look at the literature. If we look at the literature that's being published on erectile function outcomes, it ranges from about 20% to 100%. Okay? I mean, it's just all over the map. So it really comes down, I believe, to surgical experience on the one hand, but also to the anatomy of the individual patient. The degree of cancer. Some of those series tended to operate on men with more cancer, so there was less likelihood to be good nerve sparing. Some of those series were on men who had very early T1C disease, and you could leave a lot of nerve fibers there. Maybe better with robotics, we're not sure yet. But this slide here is very important, and that is that it could take 4 years for you to recover normal erectile function. Okay? So this was on about 200 potent men who were operated on, and I think the follow-up was on about 170 of them. So it was a pretty good follow-up. And what you can see is that the recovery just keeps on, it's a straight line up, increasing with time. So here's the follow-up in months, and as months go on, more and more men recover, till about 51%. This is from Memorial Sloan Kettering series, which is one of the leading cancer centers in the world. And you can see that their data is 50-50. Some of the risk factors for a man developing erectile dysfunction after surgery: age clearly plays a role. If I operate on a 45-year-old man who has perfectly normal erectile function, he's very likely going to be better off than a 70-year-old man who has marginal function. And it's probably because of the other diseases that are present. Vascular diseases, the blood supply isn't quite, the vessels aren't quite as strong, you're not getting the blood flow down the line. You may have diabetes, you may have high lipids, you may be a smoker. If it's high-stage disease, we're less likely to spare good nerves. A non-motivated partner, someone who was using PDE5s like Viagra or Levitra beforehand, and the obese patient. Okay? So it's very important to assess a patient's preoperative function. It's the playing the piano rule. If you could play the piano before, you might be able to play it afterwards. But if you couldn't play the piano before, and I'm not a piano teacher. Okay, so this just demonstrates, again from Rabani, by the way, at Memorial, who trained with us in Vancouver. You can see that depending on the preoperative sexual functioning, if a man had full erections, he was more likely to recover it than a man who only had partial erections preoperatively. That makes pretty much sense. It was just proven there. So what about rehabilitating the penis? So after radical prostatectomy, there's nerve damage, there's vascular damage, decreased oxygen getting to the penis. We don't have nighttime erections, therefore we have less blood flow and we get fibrosis. Now, nighttime erections is nature's way of keeping the penis healthy. Men, particularly younger men, get up to 7 erections spontaneously while they're sleeping. Okay? And that is nature's way of getting the blood flowing into the penis to keep it healthy. It's pulsatile, you get the blood into the penis, and then, you don't always wake up and use it 7 times a night. It could be interesting, okay? But it's nature's way of keeping the penis healthy. You lose those, clearly, afterwards, after the surgery. Not only are you not using it during the day, you're not using it at night as well. So the theory behind penile rehabilitation is by using therapies, we can stimulate circulation of blood into the penis, which will protect the smooth muscles, the muscles in the penis, the nervous tissue, and the blood vessel linings, what we call the vascular endothelium. The integrity of these structures is critical while the nerves are repairing. So I'll tell my patients, take this, do this, even if it doesn't give you an erection, it's keeping the tissues healthy while the nerves are recovering, or while the blood flow is finding its way back down there. So oxygen is a key. In the flaccid penis, the oxygen tension is only 35 millimeters of mercury in the penis. And that leads through this CGF secretion to collagen production. When the penis is erect, and thus the nature's 7 erections per night, it increases it doubles or more the oxygen tension within the penis. You get prostaglandin E secretion and decreased collagen. Collagen is scar tissue. So it's a very simple formula. Let's get the blood flow into the penis to prevent fibrosis, prevent the penis from atrophying while it's healing. And so this was a study done by Montorsi. He's a very important man in the field of sexual function. He's an Italian fellow who's done a lot of good work in the field. I didn't show you there was some basic science work that suggested that supported what I just said about oxygenation. But he, in 1997, more than 10 years ago, he just had 2 small groups of men. And it's interesting, this study's never been repeated for some reason. But half the men received intracorporeal injections with prostaglandin or Prostadil 3 times a week for 12 weeks. And the other half didn't get any erect aid. They didn't get injections, they didn't get vacuum devices, nothing. And what they found was that a marked difference between the 2 arms. Those who received the injections early on had a 67% recovery of spontaneous erections versus only 20% in those who did not undergo his form of penile rehabilitation, which was early injection therapy. So the other fellow who looked at this was Padmanathan, and he looked at using sildenafil or Viagra, and he did a study where patients after surgery, 4 weeks after surgery, were treated with 36 weeks of Viagra. And in their series, the difference was statistically significant between those who didn't get Viagra, just got placebo, and those that did, 27% versus 4%. Now the third study was this fellow Banowski, who looked at nightly sildenafil, taking a 100 milligram tablet and cutting it in quarters, and taking a quarter tablet at night, every night after the surgery. And you can see that at 52 weeks, at a year, this is the light blue line are the men who received the nightly Viagra, and the others did not. And there is a difference in the recovery of sexual function in those who received the sildenafil. And this just shows it another way, that there seems to be an improvement in men who receive the nightly sildenafil for a year. But these studies have some limitations. They're small, single center, same one surgeon. The Padmanathan group didn't compare nightly with on-demand. On-demand was, sort of, I'm in the mood, let me take one. Banowski's a small series, and what bothers me about this Banowski series is that 95% of his patients had erections after the catheter was removed. That certainly isn't the experience I have in my practice, or most people have in their practices. So a lot of questions remain. So these were, like I mentioned before, small series. Do you hang your hat on it? That's a pun. Sorry, I lost my train of thought. There was an image that when it got just, I had this image. But all of these questions remain. So these studies were not definitive. So we had to do a definitive study. When do you start? Is the drug matters? There's 3 different drugs: Viagra, Levitra, Cialis. How long? When do you start? Daily, PRN, on demand. There's only working people who were normal before, and so on, and so on, and so on. So this very large study was done across the world. It's called Reinvent, Recovery of Erections, Intervention with Vardenafil, which is Levitra, Early Nightly Therapy. And the way this study was designed, without going into great detail, was after surgery, patients were randomized. Remember I talked to you about what randomization means. So they were randomized to receive either nightly Levitra, and that was 10 milligram dose, plus on demand, so every night they were taking a pill, plus if they felt like taking another one once in a while, they took another one, but it was a placebo. So they only received truly the drug nightly. On demand, those patients, they received a nightly placebo. So every patient is, as far as they know, they're blinded. Every patient receives a pill every night. But in the first arm, it's a real pill that they're getting, and then their on demand is fake. The second is the nightly pill is a placebo, but their on demand is real. And the third group, those poor guys get placebo all around, every night and on demand. So this is how you prove whether or not a drug is effective. You have to do this type of randomized study. And it had to, because of the numbers of patients needed from a statistical point of view, to prove one way or the other, it took a lot of centers and a lot of countries. And the data supports, basically at 3, 6, and 9 months, the highest recovery rate was in those patients treated with on-demand, not nightly. So this is very surprising. This is like cutting edge. It's not even making the newspapers yet. Okay? So you'll all forget that I showed you this because you're not supposed to have seen it. It's in press. It'll be published, I think it's going to be published in October, maybe, in European Urology. And then it'll hit the press. Okay? And again, this just shows it another way, that the patients who are treated with on-demand did the best. There's placebo, this is the nightly, and the on-demand. Now, there's a lot of information that came out of this study. And my interpretation of it, and the way I am now managing my patients, is that when they've had the surgery, I still start them on the nightly. Because at the 3-month, the differences between the nightly and the placebo were significant. But once a man reaches a point where he's continent, he's recovered from the surgery, PSA is 0, and now what's left is let's get our sexual functioning going again. At that point, I switch him from nightly to on-demand. And I usually encourage 2-3 times a week of one of the drugs. So the conclusion from the study, it really was a well-designed study. It was rigorous, it had a large sample size. This is the kind of study that we need for all of these treatments that we're bandied about. And in this study, the theory, the hypothesis that nightly Levitra will be as good as on-demand was not met. Okay, Vardenafil on-demand showed good efficacy. Vardenafil on-demand worked early after nerve sparing. And these findings support a shift towards on-demand dosing for the treatment of ED in men post-prostatectomy. So that is cutting edge. Now the maximizing the effect of PDE5s, I'm going to leave the issue of penile rehabilitation for a moment and just talk some generalities about sexuality and aging in my last couple of minutes here. So maximizing the effects of Viagra or Levitra or whatever, you got to talk to the patients. Again, Stephen addressed this. 95% of what we do, there's the old joke in the surgical school, if all else fails, talk to the patient. But it's really the other way around. You really have to. So why does the patient want them? What are his or her today expectations? How will they be used? Make sure the patients understand what they won't do. They're not going to turn them into, 20-year-olds. The partner has to be involved. There's a great slide that shows this guy at the doctor's office asking for Viagra, and behind him, holding a sign over his head, is his wife that says, "Please don't give it to him." So you need to discuss it with the partner. By the way, there's the Viagra light switch. I don't know if you've noticed that. Did you see that cartoon of the, how men and women operate? For a woman, there's a box that has about 1,000 dials and gauges and switches and all of that. How to get a woman aroused. And for a man, it's just that, an on-off switch. Simple. So before people get too, interested in intercourse, I think you have to work with the Viagra, use masturbation, outer course, combine with other treatments and aids, know, you have to look at the general condition. What's the partner's condition? Is this good for her? And be aware of any unanticipated consequences or side effects of the drug. So you have to talk to the patients and make sure. The other area I just wanted to touch on is, I started my talks today about aging. And aging can change sexuality. With aging, we see a decrease in desire, erectile function, ejaculation. The volume of ejaculate decreases with aging. The intensity of an orgasm and the length of the refractory period increases with aging. These are just consequences of aging. And hold on, I'm going to call tech support because this is what happens. But there are a lot of things that can remain stable with aging as well. Desire. There's no reason why an older man cannot have a normal libido, can fantasize, preferences, can masturbate, and can reach satisfaction. Or just have a desire for closeness, a desire to be desired, a desire to feel good in one's body, a sense of humor about it, and the experience of an orgasm. So these can remain stable with age. And as physicians, we have to remember that a male who comes to our office, and I'm coming back now to male health in general, bring more than their body into the doctor's office. I mean, it's more than just the body. There's relationships, his past history, his feelings, his libido, his sexual functioning, his performance anxiety, fear of aging, partner's concerns, cultural and media messages. The interaction between partners has such an important influence on a man's sexuality. For example, I'm not the first, am I, Martha? A condom machine there. You can't see that. And but older males tend to have these assumptions. They make there's these common assumptions about older male, that they're monogamous. They may not be. They do only vanilla sex. They may not. They're sexual only with women, not necessarily. And erectile function is a central issue in sexual function. You know, you can be sexually active without an erection. And unfortunately, they have stereotypes about women. There's how the body should function, normal sexual activities and preferences. There's these assumptions and beliefs about, and misinformation about aging issues. You know, I can't tell you how many men tell me, oh, I don't have an erection, but I'm getting older, so I guess that's normal. It's not. And unfortunately, a lot of professionals often share many of these assumptions, undermining good care. So to deal with the complete man, his body, his lifestyle, his assumptions, his aging, and his sexuality requires a group of healthcare professionals working as a team. Anything less, and we're just dealing with patients, not people. And that brings us back to square one and why I think it's important to put this team together and to have a men's health initiative. So thanks very much for your attention, and I hope that the rest of the meeting